So the challenge with cavities is that it includes very many various entities, from infections to systemic diseases to malignancies, and it is our job to differentiate and not miss the diagnosis, or at least put them in the right group. I will illustrate this with cases from my practice, but the list is really long and it's endless, so you have to keep an open mind and remember that there's a lot of overlap. So in our clinical practice, we have cases when we meet this, and these two look relatively similar. One of them is a cancer, one of them is an infection. We have a cavity with a thick wall, some contents. Again here, cavity with a thick wall and some contents. So what is it? Which one is the abscess and which one is the tumor? So before we start, we have to remind ourselves about the definitions of the Fleishman Society. So the cyst is any rounded circumscribed space that is surrounded by a wall of variable thickness, and the wall thickness of a cyst is always below 4 millimeters. And there's a continuous transition between cysts to cavities. And a cavity is a gas-filled space, which is seen as a lucency or low attenuation area within a consolidation, a mass, or a nodule. So the imaging findings, what kind of findings can we use to differentiate malignant versus benign? Well, you could try to use the contents fluidity, but that's also in bronchogenic cysts, and you have maybe hemorrhaging in bronchoalveolar carcinoma, so that's not possible. You can try to use the connecting pulmonary artery, which is good for smaller metastases, but when the metastases get larger, they compress the artery, so they disappear, so that is not a good sign. Rim enhancement in cavity wall is possible in both benign and malignant. That doesn't help. It does help that there was a relatively new study that showed that perilesional centrotubular nodules or consolidations, they usually favor benign entities but do not exclude malignancies, but they favor them. And if you're wondering if a lesion is an aspergillosis or a tumor, you can try to see the contrast enhancement pre and post contrast, and if it's less than 10 HU, then it's most likely to be an aspergillosis. If you look at the symptoms, well, you can use patient symptoms to differentiate between malignancy and benign lesions. You can't really do that because acute onset is observed in both entities. If you have a fever, well, we can have a superinfection due to underlying malignancy, so that's not helpful. Cough and dyspnea are common in both entities. Hemoptysis occurs if any lesion is affected. Weight loss, well, you can also have that in a benign lesion, for instance, TB. And fatigue and malaise is very common in both entities, so that's not very helpful. So this is very stressful, but if you combine the symptoms, the imaging findings, the blood work, microscopy, and co-existing or predisposing factors, as well as the previous clinical history, then you can get to a diagnosis. So the most common infections are abscesses, which are complications to pneumonia, septic emboli, tuberculosis, atypical mycobacteria, and aspergillosis. A pulmonary abscess has symptoms similar to pneumonia because it's a complication of a pneumonia, so it's productive cough, fever, chest pain, and pleuritic pain. The imaging findings are intermediate to thick wall thickness. They may or may not have fluid levels, and enhancement with central necrosis is common, and if it's peripheral, you may have pleural thickening and empyema. So a typical pulmonary abscess is a cavitary lesion with thick walls. You have here contents, which probably is necrotic tissue. You have some wall enhancement, which you can see here, and then you have the air fluid level. This is very typical of lung abscess. I often find it very easy to see the empyema in sagittal images. It's easier to differentiate the cavity wall from the pleura. And here you have contrast enhancement in the pleura, which is typical of empyema. You might even think that, yes, maybe it's probably starting in the periphery as well. So septic emboli is similar to pneumonia, but it often occurs in immunosuppressed patients, drug addicts, patients who have central lines, patients who have undergone dental surgery, and patients who have endocarditis. So the symptoms are, again, cough, dyspnea, and sepsis. And because they're more seriously ill than the pulmonary abscess, they may be having sinus tachycardia and hemoptysis. So the imaging findings show wedge-shaped and or rounded peripheral opacities. They develop very fast from days to nodules to cavities. They have varying wall thickness, and they may or may not have rim enhancements. They often have pleural effusion and often have mediastinal lymphadenopathy. And if they have endocarditis in the aorta, they often have systemic infarctions. Just to show you some examples, This is one patient who had small nodules in the periphery, which was septic emboli. It's another patient who had nodules of different ages. We have here a cavitary lesion, which is older than this lesion, which is just starting to cavitate here. You have pleural effusion, and these are the nodules of different ages. If it develops very fast, the patients can also develop pulmonary hypertension, so you have to look for this if you suspect septic emboli, and you also have to look for possible infarctions so that you can rule out or prove aortic endocarditis. So tuberculosis is again similar to pneumonia and septic emboli, but they have low-grade fever instead of high fever. They also have a lot of malaise and fatigue, and the new thing here is that they have weight loss, and you can have cough with or without hemoptysis. And there are described radiological patterns which are typical for primary and secondary TB, but that is debunked, and they have recommended that we use a new pattern to describe imaging findings in tuberculosis. And the new pattern, although there's again some overlap, is that an immunocompetent patient has usually upper lobe cavitary disease. An immunosuppressed patient has lower lobe affection, adenopathy, and pleural effusions. You should remember that children belong automatically to the immune suppressed group. So normally in adults you would see upper lobe cavitary disease. So when you have cavities, the tuberculosis cavities have varying wall thickness. They may or may not have rim enhancement. It's interesting to show that the adenopathy may show rim enhancement, which is relatively often in tuberculosis, but not exclusively in tuberculosis. Perilesional central lobar nodules are very common. You often have pleural effusion, and if you have miliary tuberculosis, you have then cavities in the predominantly lower lobes, not the upper lobes. And these cavities are relatively small, 2 to 3 millimeters. So just a couple of examples again. This is a patient who migrated to Norway from an endemic area of TB. He had this cavity in the upper lobe with all these perilesional consolidations, and this was proven to be tuberculosis. Another patient who had no previous illness and was quite ill, and then we saw these perilesional or small opacities in the upper lobe, and we saw this one lymph node with rim enhancement, and this was also tuberculosis. So sometimes you don't have a proper cavity, but you have to look for this rim enhancement, and you have to pick it up and think about tuberculosis. Another patient, just an example of miliary tuberculosis, an elderly patient who had symptoms of pneumonia. Her GP had given her antibiotics. She had not improved, and she had 8 kilos of weight loss. Then on CT we found these small nodules with cavities, which were proven to be miliary tuberculosis. So non-tuberculous mycobacteria are very similar to TB, but the one thing that does change in the symptoms is that they do not have, or are less likely to have hemoptysis, and they also have less weight loss. It often occurs in patients with pre-existing lung disease, and you have a classic and non-classic form. The non-classic form does not have cavities. On imaging, nodules in all lobes are seen, but there's a predilection of upper and posterior lobes, or parts of the lobes. They develop into cavities with varying wall thickness. They're very seldom larger than 2.5 centimeters, but that can occur that they're large. And very rarely do you have mediastinal lymphadenopathy, and very rarely do you have pleural effusion. And the non-classic form is bronchiectasis between bud nodules. It's completely different. Just to show you some typical MAC infections is a patient with COPD, and they are the ones who are prone to get this. They have these nodules with intermediate wall thickness to thick wall thickness, cavities, also cavities in the posterior parts of the lungs, and this was a atypical mycobacterial infection. Another patient who had regular biannual routine CTs due to COPD, he had these small nodules which had been reported as unspecified small nodules, but not really, he had also no symptoms at the time, but then he came back a year later and asked for a CT earlier because he had increasing dyspnea, and then these same nodules that we see here had changed into these small cavities, and this was a mycobacterial infection. So aspergillosis infection is relatively common also. You have 4 types of aspergillosis, which is allergic bronchopulmonary aspergillosis, which is not cavitary, and aspergilloma is not a true cavitary lesion because an aspergilloma develops into a pre-existing cyst. So a cavitary lesion is always a nodule that turns into a cavity, So that's not a real cavitary lesion. I will not show examples of that, but I will show examples of a semi-invasive aspergillosis. So these patients have a true cavitary lesion. They have symptoms of prolonged symptoms of productive cough, fever and malaise, and sometimes they may have hemoptysis. On CT, you initially just see a consolidation and maybe a halo of ground glass, and it may cavitate, but it takes time to cavitate. And the halo, it consists of alveolar hemorrhage. It's not specific for aspergillosis, but it's helpful. And you can also see this around granulomatosis with angiomatosis and some cavitary methods. So this is a patient who had chronic asthma, so she had used steroids for many, many years. She had this consolidation in her right lung, and she was supposed to come back for a next chest x-ray after 8 weeks, but she waited for 12 weeks, and when she came back we still had this lesion here. So we were worried that this may be a cancer. When we did a CT, we see this cavitary lesion, and there is no rim enhancement, there's no fluid level. It has this kind of spiculae, but if you look on the sagittal, you see this halo around it. We still did a biopsy and it was proven to be aspergillosis, and then later on she developed hemoptysis, so this had to be removed. And just to show you an odd case, which is sometimes difficult, which also I initially missed, which was a 60-year-old male who had fever up to 41 degrees Celsius. He had weight loss 10 kilos in the last month, and we did a CT. We saw this necrotic lymph node with rim enhancements. We saw this large consolidation with some starting to cavitate here, another lymph node with rim enhancements, and this was a very rare disease. Patient had 6 months ago visited his family in Southeast Asia. He had only been sick the last month, and the quantiferon test was negative, so that ruled out tuberculosis. And his diagnosis was melioidosis, which is a rare disease in Europe. It is a microbe called Burkholderia pseudomallei. It's a gram-negative aerobic bacillus. It's endemic in Southeast Asia, and the most common site are the lungs. The peak age is between 40 and 60 years of age. It may or may not affect people who are immunocompromised, but the odd thing about it is incubation time lasts from days to months. So he had contracted it when he had visited his family 6 months earlier, and the symptoms are fever and extreme weight loss. So granulomatosis with polyangiitis was previously called Wegener's. It's one of the systemic disorders which cause cavitary lung disease. Then we have rheumatic nodules, and you have sarcoidosis. Cavitary disease and sarcoidosis only occurs in less than 1% of the cases, so I'm not showing any cases of sarcoidosis. But with granulomatosis with polyangiitis, we have the symptoms of small vessel vasculitis, and 95% present with cough and dyspnea. And almost all patients have nosebleeds and hemoptysis. So the imaging shows large nodules, and they have a mass which is quite large, from 2 to 10 centimeters. They become quite large, often central, but there's no predilection otherwise. They have varying wall thickness, and if you have these nodules, 25 of them go on to cavitate. 50% of all the nodules, they resolve over time, but they leave fibrosis or cysts. There's also a presentation with ground glass and mosaic attenuation after pulmonary hemorrhage. So we had an elderly patient with these nodules, first on the right lung with this thick wall thickness here, intermediate wall thickness here, and cavitation in the center. And 3 years later, there was just a small cyst which was left. Her changes on the left side were also quite large, with cavitations here, and after 3 years there was still a residual nodule and some cystic changes here. So they do resolve over time. Rheumatic nodules are relatively rare compared to interstitial pneumonias. They are symptoms of dyspnea in course of rheumatic disease. They may be asymptomatic, and there are reports of hemoptysis and cough. The imaging shows that there is subpleural or peripheral necrobiotic nodules. There is varying wall thickness, and this usually resolves over time, although there have been some case reports of sometimes reports of malignant transformation, but this is very rare. So just to show a case, a 50-year-old patient with rheumatoid arthritis with ongoing methotrexate treatment for the past 18 months. His current symptoms was increasing dyspnea, and he had a subpleural nodule which was seen on this CT when we did for his dyspnea. All these small changes are due to his rheumatoid arthritis, and this is also a small cavitating nodule. So he got steroids and changed his medications, and he got better. And we see without any special treatment, this has dissipated on its own. So malignancies, there are two types, of course, the primary and the metastasis. But you should remember that the most common solitary cavitary nodule is a malignant tumor. So if you see one solitary cavitary nodule, malignant tumor is always one of the differential diagnoses. We know that thicker walls, for instance, over 24 millimeters, it indicates malignancy. But you should remember that thin wall does not exclude malignancy. You also have other findings like changes of the septae and changes of the interlobular septae, but this is not always seen in all tumors. So you have a patient who was 70 years old, he had pancreatic cancer and he had metastasis in both lungs. On one side there were more nodules and the other one it was also metastasis, but they were more cystic-like. So you should remember that just because it's cystic or thin wall doesn't mean it's not malignant. There's another patient who had a cavitary lesion with fluid air levels, and this was a bronchogenic carcinoma. He also had a satellite metastasis, and you should remember that also a solitary tumor can have cavitation. So just to show you another example of a patient with COPD who had increasing dyspnea, we found that this cavitary lesion with one almost cystic and partly cavitary lesion with this thick area. So the cyst wall here is very thin, but this is thick. Again, this is thin and this is thick, and this was a whole cancer. So you should remember that even thin wall changes can be cancer. Just to mention, there are congenital malformations which mimic cavitary lung lesions, and due to time we will not go through them, but if you want to read about them, there's a very good paper from 2002 by Zilak. So one of the learning objectives I had was to create an algorithm for diagnosis, but it was very difficult because all patients have cough and dyspnea. The wall thickness varies and predominant location in lung varies. So there's a lot of overlap, and there is a possible way of showing it graphically. It is not always 100% correct, but it's the way what is most predominant. So if you have a box where all the patients on this side have no hemoptysis and all the patients on this side have hemoptysis, you have patients with no fever in the center and high fever in the periphery, and no weight loss up here and weight loss down here. Then abscess has often no hemoptysis and no weight loss, it's here. A septic emboli often has hemoptysis and no weight loss, but they have high fever. Tuberculosis has low-grade fever, but they have quite a lot of weight loss, so this belongs in the center. Non-tuberculous mycobacteria have very seldom hemoptysis, so this usually belongs here, and they have less weight loss compared to tuberculosis, so they are slightly higher up here. Aspergillosis has a quite often hemoptysis and has often high fever, but they don't have any weight loss, so they are up here. And granulomatosis with polyangiitis, it has also no weight loss, but it has very often hemoptysis, so it's on this side, and it has not too much fever, so it's in the middle and not on this side. Rheumatic arthritis nodules are very rare, and if we had to classify them, they would be in the no weight loss and intermediate fever and malaise area. So, and this odd diagnosis of melioidosis, which was very rare, it has no hemoptysis, but it had high fever and weight loss, so it was here. So just to show you that we have a lot of overlap, and when you then put in malignancies, they really have presentations in all four boxes, so they are in all areas. As you see, there is a lot of overlap. And if you look at imaging findings, you can also have thin wall cyst here and thick wall cyst here. You have predilection for upper lobes here and lower lobes here. You have the predilection for central here and peripheral here. If you then try to put the diagnosis in, malignancies and aspergillosis is everywhere, so you have to think of them everywhere. Then if you think of septic emboli, they are thin walls and thick walls, and they are always in the periphery, but they can also be in the upper and lower lobes, so they are like that. You have lung abscesses. Well, they are usually not thin wall, they're intermediate to thick walls, but they can be central, peripheral, and upper and lower, so they are here. Tuberculosis is also intermediate to thick wall. It's usually in upper lobe, whereas miliary tuberculosis in the lower lobe. So this would be here. And non-tuberculous mycobacteria are usually in the upper lobes, and there's no special predilection for peripheral or central, but usually in the upper lobes, and they are not necessarily always that thick, so they can have thin walls, so they'll cross over here. Rheumatoid arthritis usually have thick-walled peripheral lesions, and they can be in the upper and lower lobes. And granulomatosis polyangiitis is usually central, and they have intermediate to thick wall, and they can be in the upper and lower lobes, so they belong here. Just to get back to our two cases, we have learned that patients who have a cavitary lesion with perilesional small nodules or consolidations, that is favored to be a benign lesion, whereas this lesion has no consolidations, so this could be a malignant lesion, so then we ask for the clinical information. And this is a patient who is 30 years old with a fever and cough, and this is an elderly patient with hemoptysis, and a patient is smoker, so it's highly likely that this is a malignancy, and this was pulmonary abscess, and that was correct. So you have to think of all the symptoms and findings together. Thank you.